Good afternoon. First of all, I am not connected with any manufacturer or distributor of any of the monitors that you may see in this presentation. At the end of this session, the learner should be able to achieve the following objectives. So first, what is central venous pressure? It measures right atrial pressure and is affected by the circulating blood volume, venous tone, and right ventricular function. It is measured at the junction of the right atrium, superior vena cava, and inferior vena cava. When is monitoring of the CVP indicated? Is it to predict the preload, to predict responsiveness to fluid therapy, or for fluid and drug therapy through a central line? It is common practice in critical care medicine to maximize the cardiac output by using intravenous fluid administration to increase the preload and therefore the stroke volume. However, excessive infusion of fluid carries its own problems and is therefore best to be avoided. The goal is to ensure that the preload places the heart at the top of the ascending part of the Starling curve, which is the minimum preload to attain the maximal stroke volume. And for the longest time, CVP has been used as an indicator for fluid therapy, but it has been shown to be an inappropriate indicator of venous volume. The CVP is not likely to provide an ideal index of preload, and it correlates poorly with indices of cardiac preload that have been demonstrated to correlate well with cardiac output or cardiac index. The measured CVP often does not truly correspond to the pressure distending the right atrium at the end of diastole. Is CVP a predictor of fluid responsiveness? During the optimization of cardiovascular function, an important decision is whether to attempt to increase the cardiac output by giving additional fluid or whether to start using inotropic drugs. A desirable characteristic, therefore, of any index of preload is that it should be able to predict whether or not the heart is fluid responsive, meaning that a further increase in preload will result in an increase in stroke volume. To date, the majority of studies of the predictive value of CVP for fluid responsiveness have been unable to demonstrate a relationship between the baseline central venous pressure and the response to filling. And use of CVP measurements to assess whether or not a patient's cardiac output will increase significantly in response to an infusion of intravenous fluid cannot be therefore recommended. So is there a role for central venous pressure monitoring? There's a role for central line placement during surgery for fluid and drug therapy, but not to predict the preload in a patient or to predict if a patient is fluid responsive. And when you insert a central line, what are our options? We have the internal jugular vein, the subclavian vein, the femoral vein, or a peripherally inserted central catheter. As with any invasive monitor, there are associated complications, such as arterial puncture in 0 to 15%, and the higher incidence of arterial puncture is seen in cannulation of the internal jugular vein versus the subclavian vein. There's also the risk of air embolism, pneumothorax, misplacement, thrombosis, and infection, which can result in catheter-related bloodstream infections. Even in the hands of experienced staff, central venous cannulation has a complication rate of up to 6%. Recently, there is interest in measuring the CVP by ultrasound, and a study with the 76 patients attempted to measure the CVP by ultrasound by accurate location of the collapse point of the internal jugular vein and the center of the right atrium using ultrasound. And this non-invasive way of quantifying the CVP based on the location of collapse of both the internal jugular vein and the center of the right atrium can be used as a reliable approach for monitoring the hemodynamic status of our patients. But it removes the utility of the CVP monitoring for drug and fluid therapy during the surgical period. We also have invasive arterial blood pressure monitoring, which is essentially measuring the arterial blood pressure by a device inserted into the circulation of the patient. We more commonly refer to this as our arterial line or A line. When is arterial catheterization for blood pressure monitoring indicated? In instances where small or rapid changes may be harmful, thus requiring beat-to-beat assessment, such as in instances where you want a tight control of the perfusion pressure in cardiac surgery, major vascular surgery, or neurosurgery. In those instances where wide variation in BP or intravascular volume is anticipated, such as major trauma, major abdominal surgeries, and solid organ transplantation. For cases where we would want frequent blood sampling, especially an ABG analysis, so in cases where close monitoring of serum electrolytes and acid-base status is warranted, and in patients where measuring the BP cannot be performed by other methods, such as in patients with marked obesity or major burns. Routine arterial catheterization in the absence of a reasonable indication is not recommended since complications may occur, and thrombosis or stenosis may render future cannulation of previously used arteries more difficult. The first step is location of a palpable arterial pulse, and common sites include peripheral arteries, which are more easily located, and central arteries whose cannulation actually carry a higher infection risk. The dorsalis pedis is often spared in patients with diabetic complications or significant peripheral arterial disease of the lower extremities. The further away from the aorta the pressure reading is taken, the higher the systolic pressure reading due to the arterial pressure waves reflecting back to the heart, combining with further waves transmitted from the heart being added together. However, the map doesn't vary very much. Likewise, the further from the aorta, the further the dicrotic notch, and the lower the end diastolic pressure, and the wider the pulse pressure. So be careful in interpreting your blood pressure readings between arterial lines inserted in the radial artery and the dorsalis pedis. And complications can also arise from catheterization of arteries for blood pressure monitoring. They include pain, hematoma, vasospasm, thrombosis, and iatrogenic blood loss from frequent blood sampling or from the insertion itself if you fail to attach the tubings directly to the cannula. Essential system components required for pressure monitoring include a fluid-filled catheter and connecting tubing, a transducer to convert the mechanical energy from the pressure wave into an electrical signal, or our transducer, and a signal processing unit that conditions and amplifies this signal for display. Invasive blood pressure monitoring is achieved by the insertion of a cannula, at least a gauge 20 in adults, into an artery of a patient. And the cannula is attached to the pressure monitoring system consisting of a bag of fluid, usually 0.9% saline, in a pressure bag set to 300 millimeters mercury, a pressurized infusion set, and a transducer. And when you zero your transducer, it is off to the patient and open to air. There is also interest in using the ultrasound for arterial line placement. And two meta-analyses in 2018 evaluated the impact of ultrasound-guided access radial artery access compared with palpation alone on the first pass success to access the radial artery. And another evaluated the usefulness of ultrasound-guided technique in comparison to palpation. And the results showed that ultrasound improves the first attempt success with no significant difference in the hematoma formation or the time to a successful attempt. So it's the first try that is improved with the use of ultrasound. Our arterial access can also be used to determine fluid responsiveness. Fluid responsiveness is a relatively new concept evaluating the need for fluid therapy by checking the response of stroke volume or cardiac output to a fluid challenge. As was mentioned earlier, during the optimization of cardiovascular function, an important decision is whether to attempt to increase cardiac output by giving additional fluid or whether